Endocrine pathology, hypothyroidism. So for hypothyroidism, once again, all that you have to know is the presentation. So listen to the last video that I talked about, all the presentation for hypothyroidism. It'll be really helpful to differentiate what you're going to be looking at. Now, specifically for hypothyroidism, the patient is going to have a problem with producing our T3 and T4. And it's mainly due to an inability to respond to TSH levels, okay? And that's due to antibodies that block our receptors, okay? So we don't sense TSH. So TSH levels are going to be sky high in patients that have hypothyroidism because there's no negative feedback loop being produced because you're not producing any T3 or T4. Okay, so that's the first thing that you have to understand. Now, there's multiple pathologies that can lead to this issue of hypothyroidism, but usually it's an autoimmune issue. Number one is Hashimoto's. Hashimoto thyroiditis is the most important one you have to know. And off rip, the first thing, most high yield thing, they'll ask you probably about like 6 questions about it, is that you will see lymphocytic infiltrate in the thyroid gland with active germinal centers. Okay, that is Hashimoto's. If you see lymphocytic infiltrate, and they could say like with thyroid follicular damage or with active germinal centers, okay, they can add a couple things after lymphocytic infiltrate. But if you see lymphocytic infiltrate within the thyroid, it's Hashimoto's thyroiditis and it's hypothyroidism. Okay, they love to ask about that. All right, their favorite thing. Now the finding is going to be a non-tender thyroid. It's going to be enlarged. And once again, the issue is we have an antibody, and the antibody is against thyroid peroxidase, right? So TPL. So you have anti-thyroid peroxidase antibodies, which leads to the destruction of TPL, which is very important in creating T3 and T4. You also have anti-thyroglobulin antibodies as well. So keep in mind that this is an autoimmune disorder. But the most important thing, once again, is that you're going to have lymphocytic infiltrate. And within Hashimoto thyroiditis, you have another pathology known as postpartum thyroiditis. It's very similar to Hashimoto's, but it's just within a year after delivery. Okay, so if you have a pregnant woman, she delivered within a year ago, and she has symptoms of Hashimoto thyroiditis, and they show lymphocytic infiltrate, put postpartum thyroiditis. It's very important. But this one is self-limited, so it goes away. Lastly, they like to say at first that you're going to see hyperthyroidism because you have destruction of all the follicles, so it actually leads to an initial hyperthyroid event and symptoms, and then you get normal levels of thyroid level as it's dwindling down, and then finally you'll reach a hypothyroid state. So keep that in the back of your mind too. It's not automatically hypothyroid. It's a leakage of all of your thyroid hormone immediately as the follicles start to rupture. And so that causes an initial hyperthyroid state. But then later on, as all those follicles kind of release the T3 and T4, there's nothing left and you can't produce anymore. So you get a hypothyroid state for the rest of time. All right. So keep that in the back of your mind. You have to know Hashimoto thyroiditis and its lymphocytic infiltrate. Number 2 is subacute granulomatous thyroiditis. It's also known as de Quervain thyroiditis. And the most important thing that you need to know about this is that the findings are going to be very tender thyroid. This is the only one that causes a tender thyroid. So when you touch the thyroid gland, it's going to be very tender and painful to the patient. Okay? It's going to have mixed inflammatory infiltrate with macrophages, and they're going to have multinucleated giant cells as well. And that's very obvious to note because in the name, it's called subacute granulomatous thyroiditis. And once again, granulomatous means that there's granulomas. Hence, you're going to have a mixed inflammatory infiltrate with macrophages and multinucleated giant cells. Okay? This usually is going to follow a viral infection. So keep that in the back of your mind when reading a vignette. Lastly, you will see a decrease in radioactive iodine uptake, specifically with subacute granulomatous thyroiditis, but as well as all other hypothyroidism patients. Okay? Next is Riddell's thyroiditis. There weren't many questions on it, but if you see hard, rock-like, non-tender thyroid, then it's going to be Riddell's. Riddell's is rock-like. Next is congenital hypothyroidism. They love questions on congenital hypothyroidism. You have to know everything that goes on with congenital hypothyroidism, right? It's called cretinism, right, originally, and it's most commonly caused by thyroid dysgenesis. Thyroid dysgenesis is the number one cause of congenital hypothyroidism. Very important. Okay, and it's the most common form of treatable mental deterioration in children. Okay, the patient's going to present with pot belly. They're going to be pale. They're going to have a very puffy face and a protruding tongue with poor brain development. Okay, and the symptoms aren't going to present until after the maternal T4 wanes off. Now, treating patients with this congenital hypothyroidism is very easy. You just provide them immediate T4, also known as levothyroxine, in order to avoid a patient getting, essentially in order to avoid poor brain development. Because if I give them levothyroxine they're going to have normal brain development. So you save the child's intellectual ability by just providing them T4. It's unbelievable. Now, other causes of hypothyroidism, lithium is one of the main ones that they love to ask. Lithium inhibits the release of thyroid hormone, very important, as well as amiodarone. Amiodarone can cause damage to the thyroid gland. But most importantly, most commonly worldwide, iodine deficiency leads to hypothyroidism, and that's a question that they like to ask. Lastly, soy, iron, calcium, and antacids, but specifically iron and calcium, lead to an overall decrease in absorption of levothyroxine. So make sure that patients that have hypothyroidism that are taking supplemental levothyroxine aren't on like iron or antacids, because it leads to a decrease in absorption of levothyroxine, and they actually can't be treated, right? Because you're not absorbing your T4. So they still stay in a hypothyroid state. What I will say, make sure you know what it looks like on histology for Hashimoto's thyroiditis, specifically the lymphoid aggregates with germinal centers. They like to show photos of that, and it's very, very helpful to see that photo in order to understand it and remember it on questions. But I will say the lymphocytic infiltrate was like one of the highest yield things that they asked consistently about. Lastly, I want to talk about euthyroid 6 syndrome. All this is, it's not high yield at all. You're probably going to see one question on it, but it's just critically ill patients, and you're going to have a decrease in TSH and a decrease in T3, T4. But the way that we were able to differentiate it from central hypothyroidism is by looking at the reverse T3 levels. If you ever see an increase in reverse T3 and an overall decrease in T4 to T3 conversion, right, that's all that means. An increased reverse T3 means that there's an overall decrease in T4 to T3 conversion, all right? And that tells you that the patient has euthyroid 6 syndrome. Once again, the vignette will show you a critically ill patient, and they're going to have a rise in reverse T3, and they might see it as a decrease in T4 to T3 conversion. That's all for hypothyroidism, and next we'll be talking about hyperthyroidism.